Okay. Well, welcome everyone to tonight's webinar. Well, it's nighttime in Hawaii, but it's morning there. So this morning's webinar there, today's webinar, we're so happy to have you join us and see so many of our friends from around Asia Pacific join us for this exciting event today. So I'm going to first give it to Kieran, I believe. Kieran, you are moderating.
I'm going to welcome. I mean, you're going to welcome, but I'm going to do the opening ceremony. Yes.
Okay. So should I go? I go first,
okay.
or you go first?
I will go first, and then I will call you. Yes. Okay. Hello, everyone. This is Kiran Puri, the Director of Development Welfare Research Foundation. Today, we have all gathered here virtually for a webinar on universal healthcare for all, with special focus on older people, to mark the World Health Day and also the Decade of Healthy Aging, organized by Development Welfare and Research Foundation in collaboration with Active Aging Consortium Asia Pacific. Taking care of your health is important. It is very, very significant, because taking care of your health at any age is good enough. But more so with the elderly, because your health is important to prevent diseases from making you a victim of illness at ages above 65. Even things like simple cold and flu can progress and lead to complications. This includes secondary infections like pneumonia, bronchitis, and ear infection, or a sinus infection. If you have chronic conditions such as asthma or diabetes, a respiratory illness can make things worse. Thus, it is important to make healthy choices to strengthen your immune system and reduce the likelihood of illness. As an older adult, regular physical activity is one of the most important things you can do for your health. It can prevent or delay many of the health problems that seem to come with age. It also helps your muscles grow stronger so you can keep doing your day-to-day activities without becoming dependent on others. Today, we have a panel of experts who are going to carry the subject forward. Now, I will pass on the floor to Catherine for giving her welcome address and for taking the webinar forward. I welcome you, Catherine.
Thank you so much. I do appreciate it. And it's always wonderful to be with you every month for these webinars from the Active Aging Consortium Asia Pacific. We're just so happy that we can connect even in these times of COVID, when travel is really difficult. So I just love seeing everybody online. Thank you so much for participating. So tonight, as Karen says, we're going to focus on universal health care and older people. And we have wonderful speakers tonight. One of our speakers will not be coming, and that is Ramesh. Ramesh will not be coming tonight, but our other speakers are here and ready, and it's very exciting to be hearing from them. So welcome from ACAP. I just want to remind you that ACAP has members around the world. In fact, we just got a new member the other day from Africa, which was very exciting. He runs the Bicycles Without Aging, Cycling Without Age in Africa. And they give free rides to the elderly to take them to grocery shopping and to the doctor. So very exciting program. Hopefully will be featured in one of our future newsletters. So we are adding new members all the time. If you're not on our mailing list, please give us your email address and we will add you. Also to let you know, we have a bulletin. We love to share stories. Taryn does a beautiful job putting together the bulletin, and we featuring lots of stories. So this is bi-monthly, and our next deadline is not March 20, but May 15th is our next deadline. So it's every other month on the 15th is our deadline. So the next one is May 15th. So please join us by sharing your work and your pictures. Even a very short story is of interest to our readers. So here is our list of webinars for the year, and we've already had 3, and this is our 4th for the year. We really thank Mala, who is very, very strong in recommending good ideas and good speakers. And so this is another program that Mala has helped to put together. So tonight is universal health care, and we're hearing from a number of countries. But next month, please join us also, because we'll be talking about senior clubs, and we'll have speakers from Indonesia, Japan, Mongolia, and perhaps also Thailand. So this will be very exciting. If you'd like to speak or host at a webinar, or if you have bulletin ideas or articles or pictures, please send them to Taryn. And so now I'm going to turn it over to Mala, who is our next introducer and moderator for this session. So thank you very much, and welcome to our webinar tonight.
Thank you, Kiran and Catherine, for giving brief introduction to today's webinar and supporting this initiative. Kiran Puri, whom you heard earlier, she works closely with me in many programs on aging, be it as a contributor to chapters in my edited books or organizing grassroots and advocacy activities of our NGO. And she's involved with many initiatives besides work on aging, which relate to development of children, adolescents, and adults. So she has a coinciding program today at the American Embassy School, with which she has been associated for over 35 years. So she will soon have to leave this meeting. I always appreciate Catherine's welcome address, which sets the tone to our webinar very well. Catherine is known to many of you. She is dynamic personality, president of ACAP, and the force behind bringing us all together. Her energy and her encouragement to everyone is just remarkable. And I think ACAP would not be what it is today, gathering speed, picking up momentum, spreading its wings in many countries, if it wasn't for her leadership. And along with her, we have many members in our executive committee who fully support and provide dynamic ideas and great thoughts in putting programs in different countries, as well as on the Forum for Asia Pacific. So I'm very glad that many members of ACAP have joined. And I also see many new people who have joined in this. And our request is that they all should try to become members of ACAP, which at present is free in terms of membership. And it is a great forum to exchange ideas, to talk about new initiatives and so forth. Now, moving on to today's webinar, it was actually supposed to be held on 7th April, when the World Health Day is observed all over the world. But due to unavoidable reasons, we could not hold it then, but today we carry the spirit of it. The theme for this year World Health Day, as promoted by WHO, is to focus global attention on urgent actions needed to keep humans and the planet healthy, and foster a movement to create societies focused on well-being. While this, as you will all agree, is a relevant emphasis, but for all of us working in the aging field, we would like to relate it to older persons and to their well-being, as that always remains our aim and purpose of our work. This becomes pivotal to our thinking also because we are all in some way or the other stakeholders to the decade of healthy aging, which is being observed from 2020 to 2030, with the intention that we must aim to create an environment that maintains and enhances a person's functional ability, therein enabling them to do what they value as opposed to what the health system and community assumes that they value. In other words, pertinent issue here is what is in aging societies that contributes to older persons' well-being. Many societies have set certain priorities to achieve the decade of healthy aging. Basic to this is that, as WHO believes and states, we need sound investments in a future that enables people to live longer and healthier lives. This is not possible without imperatively bringing in universal healthcare provisions, which must include the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. For this to happen, every country must adopt certain strategies which enables everyone to access the services that address the most significant causes of disease and death, and ensures that the quality of those services is good enough to improve the health of the people who receive them. However, the question is, are countries adopting these strategies? And in aging societies, how crucially are the needs of people being addressed from a life course perspective so that the later years are healthy and older people experience well-being? It is true that countries world over adopted the Sustainable Development Goals, the SDGs, in 2015, and with that promised achieving the target of universal health care. But how has been the implementation of this, and where do we place older people in this context is the discussion point of this webinar, and we have experts from different countries reflecting on this. Of course, we would have liked to have many more views and practices being shared on this platform. But given the constraints of holding webinars, especially in terms of time, only certain illustrations can be shared. And we tried to keep the focus today only on Asia by including select countries representing the regions geographically, socially, economically, and also in terms of giving emphasis on health needs of its aging populations. So we have focus on Thailand, Indonesia, Taiwan, India, and Sri Lanka. We were also going to bring attention to Nepal, but unfortunately, the expert, Dr. Ramesh Kandal, who is Associate Professor and the head of the Department of Medicine and Geriatrics at the Repati Academy of Health Sciences in Nepal, had to undergo an emergency surgery 2 days back, and he could only communicate with me last evening, quite late, that he's unable to join us today. We wish him speedy recovery and hope he's listening to this webinar. Before I invite each expert panelist to deliver their talk on the theme, I want to mention that we will, in this webinar, only relate to universal healthcare in relation to older people, and keep in the background the fact that while countries are making progress towards universal healthcare, they faced many challenges due to the impact of the COVID-19 pandemic. Besides, aging societies have to face also specific challenges in catering to older people whose health needs are ever growing, and developing societies, which characterize all the countries we are going to be focusing on, have to, in responding to the challenges, take into consideration the increasing costs of health services in societies. Now, does this come in the way of strengthening health systems so that they can deliver universal health care? I hope we discussed today, and also we may have exposure to how countries are delivering it, given their specific characteristics, which highlight availability and accessibility of quality healthcare that is people-centered. We start the panel discussion with each panelist speaking for about 10 minutes or so. Please keep the time limit in mind so that we do have some time for exchanges and interactions at the end of it. And I would request them to highlight universal healthcare and focus on older people in terms of their country experiences. We will have Kaison speak first, who is from, she completed her master's degree in public health from Mahidol University, Thailand. She obtained her PhD in health promotion from the University of Adelaide, Australia. She has been working as a faculty member at the Faculty of Public Health at Thamsan University, Thailand. Currently, she is the chair of the academic committees of the master degree in public health and PhD programs. She is also the principal investigator of the quality assessment for primary care unit in Bangkok, organized by the National Security Office. Dr. Kaison Sumpotong has been ACAP member since 2015. Now, before I introduce other speakers, may I request all participants to please be on mute and also keep their videos closed so that we have direct focus only on the speaker to give more attention to what they are contributing. The next speaker is Dr. Susanna Nugara, who is the Vice Director of University for Family and Aging Studies at University Respatide at Indonesia. A co-presenter is a very well-known personality in the aging world in Asia, Professor Tribhuti, whom we have all known who are members of ACAP for a long time. I had not realized it when finalizing the program that they are joint presenters. Otherwise, would have included her photo and name in the poster. My apologies for overlooking this while introducing our panelists from Indonesia. I would like to say that Dr. Susanna is a young researcher with special interest in the field of gerontology and public health issues. She achieved doctoral degree from University of Indonesia in Faculty of Public Health. She's working as a Vice Director of the Center for Family and Aging Studies at the University of Respati, Indonesia, and is Senior Lecturer in Faculty of Health Sciences, University of Indonesia. The co-presenter or the co-writer to her talk is Professor Dr. Tribudi Raherjo, is a professor of gerontology. She's the president of University of Respiratory Indonesia, and her research commitments include an honorary visiting research fellowship, Oxford Institute of Population Aging, University of Oxford 2011 to 2014, and consultant for aging programs to the Indonesian government and private sector since 2011. The next speaker we would have is Dr. Ding Chang, who's popularly called Derek Chan, who is an MD and PhD, FACP, and Director, Department of Geriatrics and Gerontology, a clinical professor of internal medicine at the National Taiwan University Hospital. He's the co-chair of the Asia Pacific Fragility Fracture Alliance. I hope Dr. Chang has joined. So Dr. Ting Chan is the director of Department of Geriatrics, as I said, and he's also an attending physician of the Department of Geriatrics and Gerontology. His research focuses on drug-related problems, frailty, and osteoporosis. In 2014, he played a central role in developing the fracture liaison services at the National Taiwan University Hospital. And the two programs were accredited as a gold medal and silver medal for the best practice program of the Capture the Fracture campaign from International Osteoporosis Foundation. He worked with the Taiwanese Osteoporosis Association to host workshops to promote fracture liaison services in Taiwan. In March 2017, with 22 programs in place, he received the Best Secondary Fracture Prevention Campaign Award in Florence in 2017. He played pivotal role in developing the consensus on best practice standard for fracture liaison service in Asia Pacific region, and is co-chair of the Asian Pacific Fragility Fracture Alliance. He is also actively engaged in academic societies, including being the member of Medical Counseling Committee, Ministry of Health and Welfare, Secretary General and Broad Supervisor for the Taiwan Osteoporosis Association, board member of the Taiwan Association for Comprehensive Care of Chronic Diseases, and committee member of the Ministry of Health and Welfare Long-Term Care. He was promoted as Fellow of American College of Physicians, and he's a very good candidate to highlight the Taiwan situation. The next panelist is Dr. Dilar N. Samarveera, who's an MBBS, MD, MRCP UK, as well as MRCP London, FCCP, and PhD diploma in geriatric medicine from Glasgow. He's the consultant physician in charge of the geriatric and palliative care unit, Colombo South Teaching Hospital, Sri Lanka. He's chairman of the Specialty Board in Geriatric Medicine, chief examiner of MD Geriatric Medicine, visiting lecturer at Sri J. Vardhanpura Medical Faculty, founder, president of the Sri Lankan Association of Geriatric Medicine, and he was president from 2014 to 2017. He's chairman of the Palliative and End-of-Life Care Task Force, and he's member of the WHO expert panel on healthy aging. So as we realize, there has been a little change in the program. So on request of Dr. Sheesh Goel, he has been placed as the last panelist. Professor Ashish Goyal, who is an MD and MPH, Professor and Chair, Department of Medicine at AIIMS Mohali in Punjab, in India. He's President, Indian Academy of Geriatrics. He's a Fulbright Fellow since 2017, and he's John Hopkins at the John Hopkins Bloomberg School. He's visiting professor, University Respati Yogatra, Indonesia. He's also the representative for India of the International Network for Prevention of LWs. He has many accomplishments to his credit and is a well-known geriatrician in the country, as well as he's famous in many more countries, as he is internationally connected with the geriatric societies in different countries. I feel privileged that Ashish and I have worked on few programs together, and his professionalism is par excellence. He is a great but a quiet organizer of various activities in the field of aging, and also a mentor for many upcoming geriatricians. So with that, we move on with our presentations. And we have now the first one focusing on older people in Universal Healthcare Program in Thailand by Kaison. Dr. Kaison, over to you.
Thank you very much. Let me share my slide. Okay, can you see that? Okay,
yes,
so
very much. Yeah.
Thank you so much, Dr. Mala and Professor Catherine and Professor Putri for the introductions, and I'm very pleased to be here and welcome everyone on Zoom to attend this webinar. What I'm going to talk today, because of we have some limit of time, so I will not go too much in the detail, but I will leave my slides in the chat box in case that you want to explore, and maybe we can share some idea at the last part of the seminar. First of all, I would like to share you on the population aging in Thailand. Okay, I'll show slideshow so that you can see the bigger one. Yeah, older people in Thailand, you may have known that our Thai population is become aged society this year. Maybe start last year, because in 2021, our Thai people aged 60 years and over is about 18%. So we are aged society. And, you know, because in the next 10 years, we will be super aged society. This will be a very, not a big problem, but it's a big issue that the country have to cope, to manage, to do things that for the better quality of life for the older people. And because we have only very short time, and then many sectors need to put together in terms of the effort to help. And this one is become that we have to talk this one a lot. During the last 5 years, we talk a lot about older people in Thailand. And many research come, many initiative come during the last 5 years to make sure that we can go through the process of changing the population structure very well. Because universal healthcare in Thailand, we have a very beautiful meaning that universals indicate the basic philosophy for the national health security, for which everyone should have right to obtain universal access. No matter what reason, nobody should left out. So from this meaning, it means that Thailand provide many packages for the Thai people, including the elderly, to make sure that they can access to the health care and the quality of care as well. Look at this, because universal health care scheme in Thailand, we established in 2002 which covers 25% of the population. And the rest of the population, I mean 25% left, is covered by security scheme or civil servant health welfare, because it's a Thai government concerned with the people who before 2002, they do not have any security in terms of the health. So after we have this, it's very appreciated, because the poor people, the people like farmers and in the agriculture area who do not have private security health insurance or whatever, they can access to the health care beautifully, and is to reduce catastrophic health expenditure by 4 times since universal health care scheme introduced in 2002. So this is a benefit a lot in terms of it breaks financial barrier and involve community to participate in how can we screen the people, how can we have the people to go to the right channel to access to the health benefit, something like that. And as I mentioned earlier, in Thailand, we have about 3 schemes for the health insurance. The first one is cover, the largest one is 75% of the Thai population. That is universal cover scheme. And that we are going to talk today. And the second one is social health insurance benefit scheme for the people who work with the some companies, some organization that not government, private sector is about 17%. And for the people who work with the government, they will be under the civil servant medical benefit scheme. That is about 8%. But the health coverage program here is can be the same for 3 groups, but different in terms of the financial support, different in terms of the package in the detail, but the quality and the basic essential is the same. So now today we are going to talk about the focusing on the elderly. So I show you this that we call universal health care program for the elderly, that we call elderly seamless care in Thailand. This can be the overview of my presentation today. Look at the 4 groups on the top of this slide. The first group is we call pre-aging. That's cover adults that's under 60. So the universal health care program is cover health promotion and prevention that we call PNP. And for the second group is active aging, or the people who is over than 60 and older, but they're still healthy. There's a productive and they're healthy. So they can attend the PNP and also screening. The screening package for older adults here is about 9 items: cognitive screening, hearing tests, eye exam, functional ability, nutrition, incontinence, depression, oral health, and ADL. If you have screening and you get some something that is abnormal or something this is not quite well, then you can go to early diagnosis, you can go to OPD service, and maybe you primary care units or hospital to get that done with the doctor or health professional. And if people who age 60 years and older have some acute condition or rehabilitation in comprehensive rehabilitation, you can go to the critical care, intermediate care, and you get better, you become active again. And if not, the condition is become chronic, you can come to the last part in the green circle here, or if you are dependent, and then you can get the long-term care. And that is Thailand focus on home and community-based care. And maybe perhaps they can have palliative care until the end of life or in the community. This seamless care for elderly is become like to make sure that everyone can go to the right channel and nobody left out, so that it will be a meaning of the universal healthcare coverage. And for the foundation of these 4 groups, Thai government particularly for the Ministry of Public Health focus on health literacy. So that health literacy is for the elderly, for the family, and for the community as well, so that it can become a foundation for the seamless care. Next, as I mentioned about the PNP and long-term care program, actually PNP is very important because it's kind of to protect the people before they have a disease and protect the people from injury. And disease screening is quite important too. So, and the long-term care for the elderly is just start in 2016, but before that they have some kind of pattern or model of long-term care, but maybe not so kind of the mechanism or things it maybe it's not effective. So now we have like a new model of the long-term care. So look at this for the PNP. Since introducing the Universal Coverage Scheme in 2002, National Health Security Office, where I work collaboratively with them, they develop benefit package that include comprehensive health promotion and disease prevention. The target for the PNP is not only the elderly or adults, they cover every age group and cover every situation of the life span. So the first one is pregnancy and pre-birth or pre-birth, infant, children under 5 years old, children and youth and adult and elderly. So these 5 groups can access to or they can get benefit from this package by free of charge actually. Look at the adult and elderly for the PNPs is kind of the disease prevention programs, vaccinations and screening, particularly cancer screening. If you are a woman, it's 30 to 59 or older than that, maybe you can have that. So we call it cancer screening or breast cancer screening. And the last one is quite important because now non-communicable diseases have a high number of the people who have this. So the PNP program have a health lifestyle counseling program that's available for everyone to get access to this kind of program. And because it's a non-communicable disease, is called, I mean, the cause of the disease is come from the unhealthy lifestyle behavior. So if we can change them, if we can make them, empower them to change their lifestyle, it means that they can cope with the chronic disease very well. Look at this, the use of the PNP statistics show from 2015 to 2019. You can see the number is increasing, the percentage of the people who have diabetes screening, hypertension screenings, and cervical cancer screening, and also the seasonal flu vaccines is increasing. But I think after 2019, because it's a COVID pandemic attack many countries, so I think the PNP program and PNP use should be reduced because the people feels very concerned to go to the facility, go to the hospital. So that will become in the future, how can we get them back to the PNP program again. As I mentioned that we have primary care counseling as I'm part of the training program, trainings coordinators. We launched the program of training for primary care counseling for the health personnel who work in the private clinic that register to the National Health Security Office, and they become a PCU, primary care unit. They need to have a certified counselor to counsel the people with the chronic disease and cannot adjust their lifestyle, cannot understand or about the health literacy is low, something like that. So we, last 2 years, we produced about 100 people and more to fill in the primary care unit. That is a private clinic, because a government clinic, they have the personal health personnel who train this already, but for the private one, they do not have one. So our faculty kind of the manager for this program. Unfortunately, we do not follow them now because it's a COVID-19 situation is still on and on. So we hope that in the future we can follow them to look at their capacity, skill, and the outcome, both quality and quantity of the primary care counseling in the future. For the long-term care, it's increasing demand in Thailand because we have a society, and also we have a high prevalence of chronic disease, as I mentioned earlier. Also, the family structure in Thailand is changing, lead to decrease in capacity to take care for older people. So long-term care, that is a start for the last 5 years in Thailand. Systematically start is quite important now. The concept of the long-term care that is proposed by National Health Security Office is that the policy of leave no one behind, community-based care, because we learn from other countries that when you focus on the institutional care, and there's a lot of financial problem, so we use our it's a strong points of the country, communities and families, so we base the care on home and community base. We have a good financial mechanism that we think that it can provide care continuously, and the long-term care will not stop. And the family roles are still important, but they need support. And also community resources are utilized for this package. This is a step in implementing long-term care for dependent elderly. You can see the 3 parties that is very important for the long-term care. The first one is National Health Security Office here. It is a funding resource, funding agencies, and provides finance budget to service provider, that is the district hospital mainly. In this year, we have about 6,128 district hospital who will run long-term care in the community. Another one, this is very important, is local administrative organization. This is have a responsibility to take care of the people in that catchment area. So they work together. Service provider will train care managers, caregiver, and deliver services, but LAO will be a system to run some activity and support in terms of manpower on housing and welfare for the family with the long-term, with the dependents elderly. Look at this, for the long-term care, we divided the elderly who dependents into 4 groups. The first one is need to have a mind dependent. They can move, but they may need help with eating and toileting. And the second group is the same as the first one, but have some cognitive disability. The third one maybe cannot do things by themselves, both eating, toileting, and have a severe illness. But for the last group is kind of the end stage of life for the elderly. So these 3 groups we can have statistics to show here. The people is under 60, we still have this pattern and can access to the long-term care as well. But if we focus on the people who is 60 and over, we can see that the group 1 is 61%, the big number. The yellow one is the 4 group is about 6% that need help. This is, I show you the benefit package for the long-term care, and you can see that the health services and they have a categorized into 4 groups as well. So the care managers and the caregiver will work together in terms of the care plan and get support from the healthcare provider and get support from the local administrative organization. I would like to show you just before the last slide. I think I ran out of the time now. The key success for long-term care in Thailand. I think this is analyzed and synthesized by National Health Security Office, saying that long-term care have a national policy that's announced in 2015. And also the integrated care with multidisciplinary cooperation at the community level. The capacity building of manpower such as care manager and caregiver, they train because local organization that want to register for the long-term care funding, they need to have a care manager and caregiver, so they train them. And the financial support that's come from long-term care fund and also National Health Security Office. And data and reporting, they have some program. And the last one of the key success for long-term care is that Thai culture, because the volunteer for older people is a merit, is beyond. So in our culture, taking care the elderly is certified. I mean, is very important. The people will feel very happy if you do that, and this is become a key success for the long-term care. However, we still have some challenge in the future because during the COVID and post-COVID pandemic, the budgets for the service will be decreased. So this needs to be do something. And also the unforeseen health-related sickness among older people, we do not know what's going to come next after the COVID. So we need strong system. We need to be resilient so that we can cope with the fact that if something might happen in the future. About the digital disruption that's occurred now, we need digitalized technologies. We need to design whatever that use digital and technology, so that the people will not stop just in the past, but they have to go in the future. And the government should seek the participation from all sectors to collaborate in taking care for the older people, so that the system for long-term care and also for the P&P program will be sustainable, and it means that the quality of life of all people who, no matter what age, will be taken care of. So this is, thank you so much. I think I might have spent longer than you give me 10 minutes, but thank you so much.
Thank you so much, Kason. I really appreciate your talk and the fact that you shared so much of information in such a short time. We now move on to the next presentation, which is on older people and universal healthcare program in Indonesia. This is by Dr. Susanna and by Professor Tribhuti. Over to you, Susanna.
Thank you so much, Dr. Mala. Okay, let me share my slide presentation. Well, first of all, I would like to express my gratitude to Dr. Catherine and other ACAP board member, and also to Dr. Kiran Puri for inviting me and this and sharing Indonesian universal healthcare for older people. And also special thanks to Dr. Mala Kapur for organizing this webinar in very well organizing. And all speakers, and also for all attendees on today's webinar. Good morning, and thank you so much for joining today's webinar. Okay, let's start from the background. The number of older adults is growing annually unprecedented rate, and significantly more individuals are experiencing increased longevity. As Dr. Kesran said, that not only Thailand, but also in Indonesia and some other country also facing the same issues on aging population. And in Indonesia, by 2020, we have approximately 9.9% of older population. It is approximately 27 million and expected to reach 15% in 2035. The universal healthcare for Indonesian older people. Countries around the world have committed to achieve universal health coverage as part of sustainable development goals that agreed by United Nations member and intended to be achieved by 2030. Nonetheless, important population groups such as older people are rarely examined as part of sustainable development goal in monitoring and evaluation effort. So strengthening the universal health care for older adults will require greater tailoring and targeting or benefit to meet this population health need while protecting them from any catastrophic health expenditure. The health condition of Indonesian older people are that the aging process during degenerative process in older people that increasing the number of non-communicable disease. And here we can see that we have 64% of older people who suffer from hypertension, and followed by dental problem, arthritis, and some other non-communicable disease. But also we have some nutritional issues such as severe teen underweight, undernutrition, and also overweight, although we still have more than 50% of normal weight added. And communicable disease still exists. This is before, this data is taken before the pandemic of COVID-19. So the upper respiratory tract infection is the highest communicable disease suffered by the elderly, and otherwise, on the other hand, mental health also, mental health issues also suffered by the older people, accounted 12.8% of mental disorder and other depression. And the dependency level accounted for 26%. So from mild dependency to total dependent, although we still have 74% of older people are still independent. The stroke is the highest cause, the first cause, the major cause of disability in older people. The challenge in developing health services for Indonesian older people is first because the number of older population is continues to increase, and also followed by increasing the degenerative disease. And we have limited number of age-friendly community health services. We have only 48% out of 200,000. And hospital with integrated geriatric care services, we only have 14 services in referral hospital. And also we have limited number of trained healthcare workers who well understood in elderly care issues. And the demand of long-term care is also continues to increase. Then optimization of research is urgently required. And our country are exploring ways to help other people retain their health, functional capacity, social participation, and security. So WHO developed the regional framework for healthy aging that consists of 7 strategic elements. And this especially aligning the health system to the needs of older person. Furthermore, this strategic framework, the regional framework, followed by national strategic action plan for health for older people. So we have 6 pillars of national strategic action plan for older population in Indonesia. It is just launched last year. It's under the presidential decree. So the second pillar is to improve the health status of older people. And this pillar is and then followed by national plan for health of older people. The national action plan for older people consists of 6 strategies: develop disseminated regulation on older people health services, improve the quality and quantity of age-friendly healthcare services, and also to ascertain the access, build and improve a network of older people's health services, and increasing the participation of older people to improve the public health, increasing participation of family, elderly, and community to improve the health of other people, and increasing the availability of data in the field of other people's health. Of course, this strategy is emphasized on indicator of access and quality of health services that ranging from promotive, preventive, curative, and rehabilitative. And based on according to the national plan for the health, national action plan for older people, we create the minimum requirement for healthcare services for older people in Indonesia, that every citizen aged 60 years old or more need to have health screening according to the minimum service standard. And each district or local government are required to provide health screening according to the minimum standard of older people in their working area at least once a year. However, the target is only 46% coverage in last 2020. I think after the pandemic, this coverage might decrease, or it's still questionable. And what is the scope of minimum care services? It's education on hygiene and healthy lifestyle, screening of risk factor for communicable and non-communicable disease, such as anthropometric measurement, height, weight, abdominal circumference, blood pressure, blood sugar, blood lipid profile measurement, and mental disorder examination, cognitive disorder examination for the level of dependency using Barsel Index and also Lawton Index, instrumental activity daily living, and the history of risky behavior. And then based on this screening result, the lowest level of primary health care will provide hospital referral for those elderly with health problem and providing health education for the healthy elderly. This is the mechanism of long-term care services in primary health care. This is the older people in home and a nursing home, and then they will have detection or screening that will be provided by social worker, health worker, volunteer. We have lots of volunteers that are active in promoting active aging in Indonesia now. And then primary health care. And if there is any problem, they will refer to the hospital, and they will have another geriatric assessment to divide which facility to refer to, such as if they don't need to stay at the hospital, they can have home care that provided by primary health care, or they can send to the residential nursing home or nursing home, and also transitional care of sub-acute care. But this facility is not provided yet in Indonesia right now, but it is our future plan to provide long-term care in community. Yes, this is the Yep, the basic concept of in developing health services for older people is that healthy elderly people are expected to stay healthy by optimizing physical and mental health, cognitive and spiritual function through promotive, preventive effort, including empowering the elderly. Those who are unhealthy are expected to improve their health. They will have referral to hospital with integrated geriatric health services under referral system, or they can join with the community-based or age-friendly services in the community health centers. However, whether they need long-term care services. These long-term care services is mandatory to strengthen informal caregiver, fulfillment of formal caregiver, development of standard for long-term care services, and also palliative care and end of life. What about those pre-elderly and healthy elderly? They will join with the health screening and early detection for at least once a year, and they will have empowerment. It is normally held by the community-based NGO or some other organization, and so they will have integrated program. They will join integrated program and Posyandu or Pospindu. Posyandu is post-force integrated services that is targeted for the older people or pre-older people. It is age 45 to 59. And the community-based long-term care service for older people is also, of course, targeting. It will depend on the result of the screening. So those who are having disability, including dementia, and also moderate to total dependent, this is the indication for having long-term care services. And long-term care services in Indonesia carried out by considering cultural aspect in Indonesia, which is still maintain the extent of extended family. So family will become the main informal caregiver for the elderly, and also the key person in providing long-term care in family base is caregiver, informal caregiver from the family. Therefore, they need to be trained to have to provide the minimum requirement of long-term care services. The model of community-based long-term care services provided by community health center in Indonesia is like this. So it's all managed by the head of puskesmas or community health center, and then they will have at least 2 or 3 manager, and then this manager will supported by 1 social worker to perform home visit or to provide caregiver, or another one is to become a case finder. If so, they will go for home visit and finding if there are any cases for others that need to have advanced care, they will bring and provide a referral system. And also this community lansia in community base, they will have health promotion and prevention program from the local government or some other NGO. And those who need a long-term care, they will be sent to the long-term care facilities, or if they need acute care, they will be sent to the healthcare facilities. Yeah, this is several concepts of long-term care services in Indonesia. Home care is a service for meeting daily needs by long-term care caregiver who live in their own homes. It means family caregiver, or who work as a social worker to provide long-term care services in their community. And normally they have, we call kader or volunteer, or in my hometown we call it sahabat lansia or relawan. So these people will provide home care for home visit to maintain the health condition of the elderly, although they don't have any indication to go to the hospital, but they still need support in performing daily activities. And panti or residential.
Yes, Susanna, can I request you to please wind up because we are running short of time?
Yes, this is the last one.
Okay, thank you.
Okay, yep. This is the long-term care services that are provided in Indonesia. But the coverage of health insurance is so important thing to inform to all of you. 24% of the total claim from national health insurance is from the older persons. So older people are using 24% of the total claim from national health insurance. So lots of older persons are using these services to maintain their health. But the ownership of the national health insurance is only 60%, 68%. Maybe it's just maybe because of the access and some other issues. Okay. Yep, this is our future vision in integrated care services for Indonesian older people. An integrated program for government and private sector, and then this the entire program that need to be strengthened by the government and also some other parties. So the development optimizing and improving coordination is private government and private institution is very important. So strengthening and coaching caregiver by paying attention to health protocol during the pandemic of COVID-19, and development on financing system and long-term care insurance for the elderly so the region, and raise public awareness about long-term care prevention, and also building innovation in long-term care information system. This is our big homework. Okay, that's all my presentation, and thank you so much. And I'm so sorry for accessing my time. Thank you so much. Have a good day.
Thank you, Susanna. Appreciate the information you have given. It was very interesting, and I'm sure, as I see in the chat, many people are liking yours and Kaeson's presentation. So please keep up your chat conversation, because we may not have time for interactions as we are running a little late. And now I take the opportunity of inviting Dr. Ding Chang Shang, who is going to speak on healthy aging in Taiwan.
Hi, everyone. I'll try to share my screen. Okay, so can everybody see my screen?
Yes, we can. Yeah.
Okay. I'll try to be on time, and also apology because I have a clinic maybe 20 minutes later. So after that, I need to get offline. So thanks for inviting me to this meeting. I'm Derek Chen from Taiwan. Today, I'm going to talk about healthy aging in Taiwan. So this is the table of content. First, I'm going to talk about the health characteristic of older adults in Taiwan. Then some brief definition and framework of healthy aging. And then to reach a healthy aging, we need to have good health service, long-term care, and age-friendly environment. Then I'm going to show you how Taiwan is going to reach all those goals. So first part, let's see the Taiwan population. Right now, it's in 2022. In 2018, 14% of Taiwanese population were 65 years age or older. Right now, it's roughly 16 to 17%. But in 2025, we expected that 20% of Taiwanese population were older than 65 years of age. And if you look at the chronic conditions, right now, about 85% of older adults have at least one chronic conditions, and 64% has two chronic conditions, and about 43% have three chronic conditions. If you look at the top 5 chronic conditions, the first one is hypertension, and followed by cataract, heart disease, stomach disease, and joint disease. And those codings are from the National Health Insurance that I'm going to present a little bit later. So then let's move on to the healthy aging. WHO considers healthy aging is a more holistic sense, one that is based on a life course and functional perspective. And later on, I'm going to show you the framework about this. And it defines healthy aging as a process of develop and maintaining functional ability that enables well-being in older age. So then if we move on to this framework, we can see that initially everyone has very good stable capacity, and later on our function is getting a little bit worse, and then in the later stage there's significant loss of the capacity. But if you have good health service, long-term care, and environment, maybe we can push a little bit up the functional ability. So in that sense, let's look at what we do in Taiwan in terms of all the 3 perspectives. The first one is the preventive service. In Taiwan, this part is not covered by health insurance. It is actually covered by the Health Promotion Administration. So every year, roughly 1/3 of the Taiwanese population, they will receive the preventive service, including health examination, some cancer screening, and so on. And then if you look at the health insurance, no matter outpatient or inpatient, right now, the older population is only about 16%, but the case percentage is roughly about 30 to 40%, and the medical expenditures is about 40 to 50%. So you can expect when the population go to about 20%, the medical expenditures are expecting to get a lot higher. And the coverage rate of health insurance in Taiwan is roughly 100%. And nearly 93% of medical institutions in Taiwan that are contracted with the national health insurance. The coverage rate and the access rate in Taiwan is pretty good. It's ranked pretty high in some healthcare index. So let's move on to the long-term care. Long-term care in Taiwan is also not covered by health insurance. It is covered by a funding from tax. So we start to have the long-term care reform since 1998. Then we call it long-term care 1.0, but in 2017, we moved to the long-term care 2.0 reform. So the differences between the 1.0 to 2.0, first is expand the coverage to more populations. So initially, we only cover people older, such as those with ADL, function limitations older than 65 years of age. But later on, if you look at on the right-hand side, we cover people with dementia age 50 years or older, and with disability age 49 and under. So then we expand the coverage to more disabled people. And the second part is we try to expand the service. Initially, we only have 8 different services. Right now, we expand to 17 different services. Among them, the number 13, community comprehensive care, is the one we devoted the most resources into it. We want to make sure most of the older adults, they can age in place, so they can use a lot of long-term care services in the community, so they will not use too much long-term care services in the institutions. Then last part, let's move on to the age-friendly environment. The first part is that Taiwanese government, they try to promote the age-friendly cities. So they formulate the public policies for these age-friendly cities. And then they build some supportive environment and increasing the powers of the city and countries to promote the age-friendly cities. They also do some award to select the best cities. So you look at the next slide, we can find that right now in 2020, we already have 323 cities or counties. They have submissions to become the age-friendly cities. And then among them, 41 got different awards. And on the other hand, since 2010, we already promote these age-friendly hospital and health services in the country. So it's been an ongoing efforts for about 12 years. So if you look at the map here, Right now, we already have 645 age-friendly hospitals or healthcare institutions. To certify as this institution, you need to go through some accreditation process. And then every 4 years, you need to also renew the certifications. And then because of the pandemic, right now, we kind of postpone the recertification for 2 years. So in summary, the health aging is the process of developing and maintaining the functional ability that enables well-being in the older age. A public health framework for healthy aging includes proper health service, long-term care, and age-friendly environment. Right now, about 30% of older adults use preventive health service in Taiwan. And among Taiwanese population, older adults were about 16%, but they use about 40 to 50% of health insurance resources. In 2021, about 10% of older adults use long-term care 2.0 services. And we already have 323 age-friendly cities and 645 age-friendly healthcare institutions in Taiwan. And thank you so much for listening to my talk. Thank you.
Thank you so much, Dr. Chan. Really appreciate your delivery on healthy aging in Taiwan. You have a vast experience and many initiatives taken, and thank you for sharing this information. We hope to keep in touch, and now we focus on talk about older people in Sri Lanka by Dr. Dilar Samaravira. Dr. Dilar, please.
Yeah, thank you very much, Mala, for giving me the opportunity, and she maintained email contacts up to date to organize these lectures. Thank you very much. So I'll be talking to you about Universal Healthcare Program, bringing focus on older people in Sri Lanka. So we've gone through the definition, but let's see how Sri Lanka has done in regard to achieving these promotive, preventive, curative, rehabilitative, and palliative health services delivery. To give you an introduction, Sri Lanka is an island very close to India, and it is home to 21. The country's population is rapidly aging, and the percentage of those over 65 years of age increased from 3.7% in 1970 to 10.8% in 2019. The 60 years and over will reach 16.3% this year, and by 2052, 1 in every 4 persons will be 60 years or over. Also, it is important to note that during this process, we have also noticed a feminization of the elderly, which you can see in this population pyramid compared to 1981. So the population pyramids in 2019, you can see how in the center the pyramids have enlarged, and also the higher proportion or the percentage of women compared to men in aging. So we are also undergoing these rapid changes in the population, demographic changes with feminization of aging as well. Also, in regard to achievement of health goals, Sri Lanka has done well in the past. During the past 2 decades, life expectancy has increased, as well as healthy life expectancy. But it is important to note that there is a significant gap between men and women. So the life expectancy of men being around 72 years at present, and of women being around 80 years. So there is a significant gap, which is thought to be due to poor health habits of men, as well as poor access of healthcare by men due to their involvement, employment, and so many other aspects. Also, it is important to note that healthy life expectancy, even though it has increased in men as well as in women, there's a gap between life expectancy and healthy life expectancy, showing that as people grow old, they are also growing old with diseases, non-communicable diseases, giving rise to more need for long-term care. And giving the top 5 causes leading to years of life loss and years of life with disability and disability-adjusted life years, you could see that in men, ischemic heart disease and diabetes play a major role. They're the top causes, while in women, diabetes has overtaken ischemic heart disease and stroke also has come in. Also, there are other non-communicable diseases which are contributing to problems and disability in old age. However, we have healthy lifestyle clinics throughout the country, and these clinics would help in detecting, screening these problems of the middle age and the elderly, and also directing them for treatment. And we also need to promote good health to prevent these diseases in the older people, which is done in all the health sectors in our country. Now, Sri Lanka is a low middle income country, but you may not know that we gained upper middle income status in 2018, but was reverted back to low middle income status in July 2020. But as you know, due to the current problems that we are undergoing, the tensions in the country and the economic crisis that has occurred in the country, we would even become lower income country and losing the middle part as well. So, however, Sri Lanka has good health indices. We even fare better than the upper middle income countries, in fact. So if you take the life expectancy at birth, males and females both are doing quite well. And also healthy life expectancy is also impressive. And as regards to maternal mortality, neonatal infant mortality, Sri Lanka has done well. But we should not be complacent in countries, but our emphasis, the health ministry, the emphasis is to reach targets of countries like Canada, Australia, and Netherlands. Let's see how we can do in the future with all these problems that we are undergoing. Speaking of policies, we have a National Elders Charter enacted in 2006, and there's a Protection of Rights of Elders Act enacted in 2000, and there's a National Policy for Elders enacted in 2006, and also was launched in 2017. And there's a National Council for Elders for promotion of these health activities as well as protection of the rights of the elders. And under the National Council for Elders, the main implementing and funding body is the National Secretariat for Elders. And the National Secretariat for Elders is responsible for many activities, and these are few activities that are highlighted, which I will not go through one by one, but programs such as maintaining daycare centers and functioning of elders committees and so on. And elders identity card is something that is given to people over 60 years in this country, but which needs more recognition. We know that it is inadequate because recognition is not appropriate for this card at the moment, even though there are benefits. And also, there is a network of elders committees in this country. So throughout the country, we have provincial, district level committees, and these committees are also coordinated by the National Secretariat for Elders. And there are many day centers for the elders, and the funding is arranged by, again, the National Secretariat for Elders, and there are approximately more than 230 elder centers in the country. Speaking of the state healthcare system, almost all preventive care and most of the curative care needs of the country are provided by the government health system. free of charge at the point of delivery. The state healthcare system handles curative as well as rehabilitative care. Now, speaking of the rehabilitative domiciliary care, we have to admit that it is quite poor in our country, owing to the absence of adequate health cadres such as physiotherapists, speech and language therapists, occupational therapists, social service officers, and these allied health workers are very much scarce in our system. We have started a program of reorienting primary healthcare system with strengthening of the general practitioner system, as well as employing a public health nurse to look after geriatric and palliative care and coordinate the community services in liaison with the services in the tertiary care level. But it is still at a level which is not happening island-wide. And speaking of long-term care and palliative care, currently, I have to admit that our services are very limited. And I've listened to wonderful presentations from Thailand, from Indonesia, but I have to admit that we are not up to that level at the moment. So we also lack a good national security or social security system in our country, and there is poverty in old age with high out-of-pocket expenditure, where people have to spend to seek treatment from the private sector as well. Well, there are 5 different schemes for social security, such as a civil pension scheme, employees provident fund, employees trust fund, farmers pension scheme, fishermen's pension scheme. But it is only 30% of the over 60 funding programs, which they provide about 2,000 rupees per month, which is highly inadequate, and that's not an alternative for a proper social security system. So we lack a proper social security system. And these are figures to show that disabilities in the aged, as people age over 70 and over 80, so the older people, they are having more disabilities. These are the figures to show that vision, hearing, walking, cognition, self-care, problems with communication all have increased. So indicating that there is a need for long-term care and need for a proper system of long-term care. Now, speaking of inability to perform activities of daily living, these are some studies from the Asian Development Bank and the Sri Lanka Aging Survey, statistics from the World Bank. So it shows that as people age, there are disabilities and inability to perform activities of daily, more than at least 2 activities of daily living are impaired in most of the 80+ people. And this is how Sri Lanka compares with other countries. And you could see that our percentages could be still less, but we are moving very fast, and our population is aging rapidly. So we need to develop, as in other countries of the region, proper long-term care services. This is to show you what we have. We have only the elder care homes for people. We don't have long-term care institutions or a proper system. So you could see the numbers. Public, at the time the study was done, there were only 5 public homes run by the government, and the private for-profit about 30 and non-profit, very few numbers. So this is highly inadequate to serve the long-term care of the patients. Also, on the whole, we have very limited number of doctors and nurses for 1,000 population. The number of doctors and nurses are shown here, number of doctors and the number of nurses compared to the other countries. So it shows how limited these human resources are for any person, be it older or young. So also, speaking of these services, we are aware that the allied health services such as occupational therapists, physiotherapists, these services are quite limited to cater for the elderly in our population. So the palliative care, now it's very important to have palliative care and end-of-life care in a country. So only recently we initiated the guidelines on end-of-life care, the professional group in the Sri Lanka Medical Association, where I was actually the chairman of the committee, the palliative and end-of-life care committee, and we had a professor to head this group, and we came up with end-of-life care guidelines. Professor Chang was the leading professor there. And anyway, so speaking of palliative care, we are in the process of developing consult services operating from the tertiary and the base hospitals, and then building up teams with doctors and palliative care nurses, and then this team serving the other hospitals in the under the tertiary care hospital, as well as providing community support and home-based care. So there's a model in development. And we have a directorate for youth, elderly and disabled persons, which is a focal point in the Ministry of Health, and which has also lined up many activities. And we have a national elderly health policy, which was launched in 2017. Now, this aims to ensure a comprehensive healthcare package for older persons to maintain good health. And this aims to have equitable delivery of health services to older persons. However, no national health policy is complete, ladies and gentlemen, without a delivery plan. So there is a delivery plan. Now, the key points in this delivery plan are building a National Institute for Geriatric Medicine, establishing stroke units at selected hospitals, improving rehabilitation units in selected hospitals, improving infrastructure facilities and services to make them elderly friendly, and such as this development of elderly friendly cities, which we have one city which has already been developed, developing prosthetics and orthotic centers in accordance with national guidelines. So develop long-term care institutions for older people in identified hospitals. We have identified several hospitals already, and aims to improve primary care services, as I told you, and aims to develop and improve human resources to improve cadre numbers, as the cadre numbers are quite low at the moment for care of the elderly in the long-term and rehabilitation units. So the major challenge, ladies and gentlemen, in achieving these goals is the economic crisis the country is facing as we speak today. So thank you. These are my references. Thank you very much.
Thank you very much, Dilar, and I appreciate your support and sharing the challenges and responses in Sri Lanka, which are very relevant for all of us to know, especially because Sri Lanka reflects South Asian countries, but also many similarities with some of the East Asian countries in terms of life expectancy and other aging parameters. So we now move on to Dr. Ashish Goel, who will highlight on universal healthcare program in older people in India. Ashish, are you there?
Yes, I'm here. Thank you, Mala. Good morning, good evening, good afternoon to different time zones in the world. And I'm largely going to cover universal health coverage in India. I understand that we are already over past the time that we were supposed to work on. I will be dividing my presentation into three parts very quickly. One is the universal health coverage program scheme in India, which is called the Ayushman Bharat program. Then I will talk a little bit about the situation in India in terms of universal health coverage. And I will talk very briefly about the state of elderly and the universal health coverage here. So the Ayushman Bharat program, in a nutshell, has got two specific schemes, which are the health and wellness centers and the National Health Protection Scheme. So under the health and wellness centers, it involves the comprehensive primary care in an outpatient setting, providing diagnostics and free essential drugs to all the participants and all the stakeholders, all the patients who would approach the health and wellness centers. At the same time, the other scheme is the National Health Protection Scheme. And the National Health Protection Scheme has basically looks at the financial risk protection to poor families. When these families come into financial adversity due to hospitalization of a person in the family, then who is requiring either secondary or tertiary care, the scheme provides up to $6,250 per family per year, which is roughly about 5 lakh Indian rupees or that's the equal Indian figure in that. So the financial strategies that have been offered by the WHO for supporting the Universal Health Coverage Program are increasing taxation efficacy and efficiency, increasing budgeting for health, and innovation in financing and development assessment for health. However, in India, none of these are under the Ministry of Health and Family Welfare directly, and this creates a little bit of a problem in establishing the universal healthcare schemes. In India, the last evidenced financial protection covers about 17.9%, and the prevention and treatment coverage for selected conditions has been seen at about 83%. So it has been seen that there are access issues, and maternal and child health care is easier to access for the rich and the higher socioeconomic cadres. But then that is probably true all across the world, and this is not something very specific to the Indian country. The National Rural Health Mission Program has been changed to the National Health Mission Program to cover the rural and the urban health both simultaneously. It's been seen that the total health expenditure in India is about 4.7% of the gross product, and the public health expenditure is only 30%. So those two figures definitely need to improve because they lead to a large out-of-pocket expenditure. And it has been shown that annually about 50 million households fall in the poverty, below the poverty line due to healthcare expenditure that they are required to take. In the Indian scenario, 75% of the total outpatient visits are taken care of by the private sector, and 62% of the total inpatient visits are taken care of by the private sector in India. The out-of-pocket payment as a percent of the total health expenditure in India has been found to be 61%, which is quite high. We definitely need an increased access to inpatient care and to transform the healthcare epidemiology. So there is a change in the healthcare epidemiology that is towards the non-communicable diseases. There is an increase in hypertension, there is an increase in diabetes, and there is an increase in the mental illness. The life expectancy has been increasing in the recent times, and the health schemes largely which favor hospitalization alone over a comprehensive outpatient coverage may definitely not be appropriate for the ideal healthcare needs, because they would anyway reflect back and increase the out-of-pocket expenditure anyway. Now, specifically looking at the focus on older persons, definitely the proportion of older persons is increasing, as it is increasing everywhere else in the world. The disease epidemiology itself is changing. The focus is now more on the non-communicable diseases. The hospitalization of older persons is disproportionately increasing. So all the proportion of the older persons in the population is increasing, yet the hospitalization of older persons is disproportionately higher because of the comorbidity and the specific disease character of these individuals. Even today, ageism is prevalent because of the limited resources, and preference and a priority is often given to the younger person at the cost of the older person. The awareness of the schemes under the Ayushman Bharat is relatively lower, and definitely this needs to be increased. Now, having said all this, I also see on the panel at least three stalwarts who have worked and have contributed to the universal healthcare program in India over the last several decades. And I wonder if I can request Mala to invite comments, especially from Dr. Inder Prakash, Dr. Vinod Kumar, and Dr. Ghazala Meenai, who are on the panel today. And definitely it would be a value addition if they can put in and pitch in with their comments. Thank you. I rest my case here.
Thank you very much, Dr. Ashish. Yes, I also noticed their participation, and also Dr. Inder Prakash has been putting lot of messages in the chat. So appreciate that. Thank you very much. If each one can take just a minute to put their comment and share it with the presenters, because my regrets that we are late and some people have other appointments after this webinar. So may I first request Dr. If we go according to respecting age, Dr. Vinod Kumar first. If we can very briefly comment on this issue, and then Dr. Inder Prakash. And
so I think Dr. Vinod Kumar is not there now because I don't see him on the participants, although I saw him earlier. So
yes, I did see him.
And I finished my session much in advance and saved you time so that we could have some interaction and some comments.
Yeah, so Mr. Dr. Inder Prakash, would you like to briefly say something?
Please unmute yourself. We can't hear you. Still cannot hear.
Yeah, we can't hear you.
Maybe
Prakash. If for some reason you're having difficulty in verbally saying something, please feel free to put your comments further in the chat. I see you've already put more comments. And very briefly, now may I request Ms. Ghazala Minai, who has been with the Ministry of Social Justice and Empowerment, the nodal agency for older people in India, to just in few words say something.
For some reason, we can't hear you either. Can you unmute, please?
Yeah, can you hear me
There
now?
you go. Yes, thank you. There you go. We hear you now.
Good morning. Thanks for having me, and it has been a lovely session, and we've enjoyed every bit of it. And I think Ashish has put us in a spot. The thing is that I thought that everyone will be interested in the seminar, but I have only a few things to share, and that is that Government of India has done a lot recently. A lot of schemes have come up. There is an action plan that is going run by the Ministry of Social Justice. Apart from other schemes, we have now an action plan that is in action, and a lot of activities happening on that front. So I think that this seminar, I think we should listen to others, and we'll certainly meet some other time, Mala. That would be a better thing than to, kind of, Ashish has covered most of the health part of it, but like we have a national policy that is there. Then we have a national council for the elderly, like in Sri Lanka that they were talking about. Then we have a maintenance and of senior citizens, parents and senior citizens maintenance act, whereby the children have to look after their parents in their old age, and if they inherit their property of anybody, even persons who are childless and who don't, the next of kin who will inherit the property will have to look after them. So these are the kind of, lot of legal coverage has also been given to this, and a lot of other judgments are coming from the maintenance tribunals, which are in every district, where where we talk about elder abuse, we talk about financial impropriety by young people, by their children. All that is being catered for. So a lot of activity in India is happening now on the senior citizen fund, and we're very happy because we all really worked hard to get the funds, because funds, as everyone is saying, is a major constraint in all the countries because of the large volume of the cohort. So now we have a senior citizens fund also. So a lot of activities being kind of financed from that fund. So lots of things are happening. We have old age homes, we have respite care homes, we have we also have daycare centers. So there are many schemes, there are many, and policies there, the schemes are there. So a lot of activities has taken place on the senior citizens front, and on the health side also. We are having in the primary health centers and all those places. We are now asking that, you know, in this national health mission, that elderly people should be looked after. And another sector that has grown is in the skill sector, in which the caregiver sector has really grown. And after Corona, I have now found that, you know, there are so many, the government of India is undertaking skill development programs. First, we had the National Institute of Social Development, where we have the skill development program we started for the elderly, care for the elderly. Now government has taken it, I mean, in the skill council. So now we have actually a skill council where they are training youngsters to for in caregiving for the elderly. So that industry is really, it's taking on a big way. I mean, I can feel it because, like I shared last time also, I have a mother who's 80, in her late 80s. And every time I reach out to people, I find that more and more institutions have come up that are providing services, nursing services and home care services for the elderly. So a lot of things are happening, and I think we should meet some other time and I can actually tell you all the details. Right now, it's a seminar for universal healthcare, and I think it's rightfully the thing that the people who have waited to speak in the seminar should be allowed to speak. Thank you so much, and I enjoyed this session with all of you.
Thank you very
Thank
much.
you. Thank you.
We appreciate your point that we should have more webinar in terms of specific initiatives by different governments, and over the last few years, and I think couple of years also, a lot has been done. So we will organize it. Since we are running short of time, and I can see some comments of people saying that they want to leave and they are giving their final sort of appreciation of the webinar, which is an indication we need to end. And since Kiran Puri is not here to give the vote of thanks, I take this opportunity of thanking all the participants and especially our panelists for their wonderful presentations. We hope to see you in our programs in the future, and we will take up the suggestion given by Mrs. Ghazala Minai, or maybe have her as a speaker. So as a co-organizer of this webinar with ACAP, on behalf of my organization, Development, Welfare and Research Foundation, I would welcome your comments for working together. And we close this now, and meet up again next month and month after that. And we have actually lined up programs till, I think, Catherine, till January or February.
Yes,
And
I think
we would like your
our,
suggestions.
sure, our next open slot is February. So if you have ideas, please let us know. We have lots of great ideas. But thank you everyone for coming. I know we ran over time. Please send us your articles for the bulletin. We really want to promote your programs and learn from you. So thanks everybody. I'm going to say good night now, and this video will be posted. Will be posted on our YouTube channel. Okay. Thanks everyone.
Yeah.
Okay.
Thank you.
Thank you very much. Bye.
Bye-bye.
Bye.
Bye-bye.
Thank you, Mala.
Bye-bye.
I'm from India, Balambal. Thank you. Now I would like just, may I have one question?
Nice to meet you. Nice to meet you.
Yeah.
Bye-bye. Good to see you all.
I will send Catherine, I will send my activity to the bulletin.
Oh, please do, please do. We would greatly appreciate that.
I will
Thank you.
contact. Yep,
Okay.
thank you.
Very good. Okay. Bye-bye, everyone.